Dr. Stephen Barrett. I specialize in lower extremity peripheral nerve surgery, so I've been involved with nerves, nerve injuries, nerve compressions for about 20 years now. Unfortunately, a lot of the people that we end up with are in very serious conditions because they've had such bad peripheral nerve injuries. And when I first started in about 2000, 2001, we thought we had a very ideal, so to say, a bullet in our armamentarium to address a lot of these issues. However, nerve pain, peripheral nerve issues have a very wide spectrum. So peripheral nerve stimulation is another modality that helps fill that very wide bandwidth of taking care of these patients that have a lot of peripheral nerve injuries and peripheral nerve pathology. So in about 2005, 2006, I was actually implanting spinal cord stimulators in the lower extremity, and we got great results from that. A little bit difficult because of the size of the battery and placement, but we actually did figure out a place where we could hide the battery, so to speak. Unfortunately, at that time it was off-label and there was no insurance reimbursement, very expensive implants. But we had a handful of patients that would actually pay for them because their lives were so miserable without that next step. And so I've been very familiar with peripheral nerve stimulation for more than 12 years now. So now we have the Bioness StimRouter, which is a great adjunct to the patients that we have. So I'm excited about it. We've been looking forward to the FDA approval of peripheral nerve stimulators, and so the nerve world's pretty small, so things are out there and you start reading about things, and so we knew it was going to be coming along. And so once it got FDA approval, we reached out to Bioness in order to have their reps come out and introduce us to the product. I think there's a learning curve to anything. The learning curve actually for us was accelerated or decreased, however you want to put it, greatly by their reps. The Bioness reps were very good because we already know the nerve decompressions, how to find the nerve, where we want to be. So it was really a matter of us just laying that stimulator in there and getting the proper positioning. So there's really a very small subset of podiatrists who are specializing in nerve right now. There's an association that's called the Association of Extremity Nerve Surgeons, and there's about 200 members. Now that's composed not only of podiatric surgeons, but we have upper extremity hand surgeons, and we also have PhDs in neuroscience that are all interested and focused on nerve. So they have a very high level of training in nerve. I think, in all honesty, there's really a very small group within the podiatric profession who would find this something that they would want to implement, and those would be the guys specializing in lower extremity peripheral nerve surgery. I think just the fact that the StimRouter is very easy to use. Others require a trial and putting patients through more hoops and hurdles to actually get them to the implantable stage. Also, I think the economics, it seems that the hospitals like the StimRouter because of cost and those types of things. So it's becoming very difficult now to treat patients because we have to not only make the right diagnosis and try to ultimately treat the patient, but we also have to be dictated where we can take the patient, really what we can do, pre-certs, all of these types of things. So patient care is really very difficult now. A lot of things that the patient doesn't even realize, and they can get very frustrated. It's like, well, why can't you just put this implant in next week? And the answer is, well, we could if we didn't have all of those impediments about hospitals and formularies and getting insurance approval and that type of thing. Peripheral nerve stimulation's been around actually for thousands of years because people that had pain would get into baths with torpedo fish and the electricity would make them feel better. So it's been around for a long, long period of time. We now know that peripheral nerve stimulation not only works off the gate control theory of pain, which was proposed by Melzack and Wall, I think 1962 in that area. I can't remember exactly the year, but it's thought that peripheral nerve stimulation works because it stimulates the non-nociceptive A-beta fiber, sensory fiber. Then that causes a lot of crosstalk, a lot of activity in the inner neurons in the dorsal part of the spinal cord. So when the pain impulse is coming in from the C fibers or the A delta fibers, it's kind of muted out. So that's how PNS was thought about for many, many years. Now, with work in occipital nerve stimulation, they've actually done functional MRIs and basically put patients in MRIs and with their stimulator on and with their stimulator off, and there's an incredible CNS effect from the standpoint of upregulating certain areas of the brain and downregulating other areas of the brain. So there's a clear central nervous system effect from the peripheral nerve stimulator itself. A third thing that the peripheral nerve stimulator does is that it changes the nerve at the location of where the stimulator is placed. So because the electrical stimulation is happening at that location on the nerve, it causes some phenotypic changes. So there's decreased sensitivity, sensibility in that, and a slowing of the conduction velocity. So that's a muting or a dampening effect there at the local site of the implant. Additionally, we do know that peripheral nerve stimulation does cause an increase and release of endorphins, which will help the patient's pain. So there are a lot of things going on with peripheral nerve stimulation, and we still don't know. You know, there's still a lot of things, and that's what the neuroscientists are really looking at. So the tibial nerve innervates the entire plantar aspect of the foot, and because there are so many injuries, peripheral nerve injuries that involve the distribution of the tibial nerve, we're able to now, with the StimRouter, be able to take care of that peripheral nerve injury or compression that's been there for a long, long period of time that's created a very significant chronic pain state for that patient. And we're able to now augment what we're doing. So sometimes we won't even go out distally. We will just do a proximal tibial StimRouter implantation. If we have pathology that is able to be addressed, then certainly we're going to do that in conjunction. These are complex cases, so the more we have to give that patient, it just gives us more weapons to try to fight that chronic pain that that patient's in. There's another psychological aspect as well, because we know that there's a huge interplay with peripheral nerve injury and CNS effects on the brain, depression, anxiety. Very quickly, if you take a rat sciatic nerve and you put a tight band around it, you're going to see changes in neurotransmitters. So it's really very unusual where you'll find somebody that's had long-standing peripheral nerve injuries that are not somewhat depressed or some component of anxiety. So if we give that patient some type of additional pain management, and the beauty about this is they have some control over it. So humans basically like to be able to be in control. And I think from a psychological standpoint, adding this component helps. Now that's clearly not necessarily going to be a peripheral nerve stimulation effect on the central nervous system, but there's still a lot of things in context with that patient that are going to help everything, and that's one component. We can cover almost the entire lower extremity with an implantation of the tibial nerve with the StimRouter, and higher up at the common perineal or common fibular nerve with those two. And I have several patients where we've actually put in 2 StimRouters so that we could cover virtually the entire distal lower extremity. Now, if they have a sural nerve injury, certainly you can identify that and place a StimRouter there. And then the only other nerve that would be remaining would be the saphenous nerve. And the saphenous nerve, fortunately, isn't involved so much with a lot of the pathology that we see. However, There are saphenous nerve injuries from bunionectomies that we will denervate the saphenous nerve in the lower 1/3 of the leg, and that is a very easy procedure to do and a very easy application for the StimRouter. So essentially, just by knowing our anatomy, we can virtually cover the entire lower extremity. So I think your primary indications are anything that has caused injury to a peripheral nerve in the lower extremity, as well as patients that have had long-standing superimposed nerve compressions due to a metabolic abnormality such as diabetic peripheral neuropathy. We have actually used it more for cases where a denervation is required, meaning that we have to disconnect that nerve and implant it into another area. Denervations from a patient standpoint have a much higher degree of postoperative morbidity. Those are procedures that usually we do very well with, and they're very different than denervations. When we denervate a patient, it's there's just a much higher preponderance of postoperative morbidity. These patients are already in pain, and now when we cut the nerve and translocate it in, some other muscle group, it's sort of like having pain on pain. So it's almost, if I can get that patient covered from a reimbursement standpoint on a denervation, I'm putting them in on every denervation patient, because it just adds that extra layer of protection for me and gives that patient just one more level to help attack their chronic pain. Now, decompressions are a little bit different, because when you decompress a nerve, it usually responds very well. However, there is a subset of patients that are decompression candidates for peripheral nerve stimulation, and those are people that have been in very serious chronic pain for a long period of time. So when you have a nerve that's compressed, let's say diabetic peripheral neuropathy, for example, it's an edematous neuropathy, which means that because they're not handling their glucose well, there's this pathway called the sorbitol pathway, which basically glucose ends up inside the nerve, causes the nerve to swell. Where the nerve goes through tight tunnels, it then has a focal nerve compression. A lot of people get in trouble because they say, well, they're going to surgically treat diabetic peripheral neuropathy, and that's absolutely wrong. What you're doing is you're decompressing a focal nerve entrapment in a patient that has a metabolic disease. Now, in diabetes, for example, in the general U.S. population, about 2% will develop carpal tunnel syndrome. In diabetic patients, it will range anywhere from 14 to 28%, depending on which article you look at. And you have to ask yourself, well, why would a patient with diabetes have such a high level of carpal tunnel syndrome? And the answer is because their nerves swell, and where that median nerve needs to go through the carpal tunnel, that's just a natural site of entrapment. So there's no actual nerve damage per se, except there is nerve damage, but it's not like an injury where a nerve has been lacerated. There is focal demyelination, but the peripheral nerve can repair itself pretty well. People who have compressed nerves have different types of symptoms, and they have different expressions. You can take two people with the exact same metabolic compression, and one patient will complain that they can't feel anything, and the other patient will complain of horrible burning and chronic pain, they can't sleep, these types of things. So there's different manifestations of the same nerve entrapment. So in the decompression subset of patients, we're implanting the StimRouter in patients that have had long-standing chronic pain, not the ones that are just insensate, that we're worried about ulceration, potential amputation, those types of things, where we're trying to reestablish sensation to that patient's foot. So that's where we're delineating it a little bit more. Whereas it's pretty simple. In a denervation case, if I'm doing a revision on something, then I'm going to implant the StimRouter. Now, if it's a revision decompression, it goes without, we're going to put that that implant in and be able to peripherally stimulate that patient's nerve because they've had a preceding surgery. So they're at a higher level of difficulty. I think that, you know, the risk with the StimRouter is really pretty minimal. I think it's so low that it shouldn't even factor into your equation when you're trying to treat these complex nerve injuries. Anytime you put something in, there's always the potential for infection. You're obliged pretty much when you put something in and leave it in that you're going to have to give them some antibiotics. So maybe a complication would be, well, I have to give that patient some, you know, intraoperative antibiotics, and I'll mess up their gut microbiome for a couple of weeks. So, but from a complication standpoint, I think really it's very, very small. If someone just felt that they wanted it out, you could certainly take it out with pretty, you know, fairly ease, because when we anchor our lead in the placement that we want, we use an absorbable suture. So about 3 weeks, 4 weeks, that's dissolved. So if I have to take it out, I can take it out. So I don't really deal much on the economic side, but I do know that the hospitals are not going to approve it unless they're able to get reimbursement for it. So I do know that it is reimbursable. From a spinal cord, if you wanted to compare spinal cord stimulators cost to StimRouter, it's a fraction. The answer is if I can take care of the patient and get them out of pain, we usually do all right on the reimbursement side, so I've always focused on patient outcome. And this particular implant is not unaffordable for patients. And so if their benefits wouldn't cover it, a lot of people will say, well, gosh, you know, my life really isn't so good right now. Why would I not want to invest it? They probably, if they took a trip to Europe, it would cost more than what it would cost them to have that StimRouter placed. So I think it's a very beneficial thing, and economically it seems to make sense. And you also have to factor in, well, patient might be able to function better now, may be able to go back to work, wasn't working before. So it could be a very good cost-benefit trade-off. When I was doing my MBA, and my program was for physicians and dentists, so it was concentrated on healthcare. It's like the only business in the world that you cannot calculate your cost of goods. It's just not, there is no way you can do it. And so you're essentially a store selling stuff that you don't even know what it cost you to sell. And you have people that are not involved in the transaction between the store owner and the person who's shopping in the store controlling it. So the person walks into the store, says, oh, I'd like to have that. And you say, well, yeah, that would be good for you. Go ahead and take it. And then you're just waiting and hoping somebody's going to send you some money for it, and you don't really know the cost of it anyhow. So it's kind of it's a warped business world. The other thing that's very interesting is it's the only business that I know of that what we were reimbursed in, let's say 1993, we're reimbursed maybe 1/3 of that today. Now, there's no other business that I can think of that has dramatically decreased their costs for that good or product or service that's being delivered. And yet, employee costs have gone up, utility costs have gone up, medical malpractice insurance has gone up. So it's a very difficult business in a very difficult marketplace with the way things are, you know, set against you, really, frankly. And it may be totally covered this week, and next week they'll send out a letter that says, you know, we've decided this is not going to be reimbursed anymore. So it's a tough game. Well, I think anybody that's had, you know, a fairly decent exposure to peripheral nerve and understands, you know, what you're trying to deal with. A lot of the things that we do in peripheral nerve and with my fellows is that you have to really work these patients up to figure out where is your true pain generator and what is it that we're trying to take care of. From a skill set to do a particular procedure, that's not as steep of a learning curve as figuring out what is it that I really need to do for this patient with some pretty complex pain? That's where the difficulty. So I always tell my fellows, the intraoperative part is probably the easiest thing. It's the preoperative and it's the postoperative. That's where. And a lot of people really don't want to deal with the pre-op and the post-op because they're a different subset of patients. It doesn't really add any difficulty to the case. It's, as we talked about, pretty readily reimbursed, and so really I'm excited about it because I think it just gives us one more advantage, augmentation, whatever you want to call it, to help these people that are really in very dire need of all the help that they can get. Peripheral nerve injuries can be incredibly complex and severe for these patients, to the point where there's a fair amount of patients that we take care of that are suicidal and have come back and said, you know, if this procedure would not have worked, I already had my suicide planned. So that shows you that even though you're dealing with this extremity, it's life-changing, not only to them, but also to, you know, their family. They don't do things that they would normally do. So StimRouter is just one more important tool that we have now for treating lower extremity peripheral nerve pathology. Hopefully they're doing very, very well. Now, there's basically, you can divide it into two categories. There's the folks that at 21 days, once their sutures or staples have been removed, it's like a light switch for them. They put the patch on and pain's gone. There's the other group that says, well, I don't really tell much difference. And those are the folks that we have to counsel, say, well, listen, it may be very gradual. It may be one of those things where it could take 6 months, 12 months, but remember that that peripheral nerve stimulation is having an effect on the central nervous system. So those would be the two subsets. So if a patient wakes up and they don't have a result when we start the stimulation, that doesn't mean that they're not getting better or some improvement. They'll say, well, I don't feel like this drug is doing much. And you say, well, why don't you stop for 3 or 4 days? And then they'll oftentimes say, oh yeah, it was doing a lot. So pain patients are kind of interesting because you can take them from a level 10 pain down to a level 3 pain, and they think you're Superman and you walk on water and do all of these other things. And then at 3 months, that 3 then becomes a 10, and now you're a goat, and you weren't so good. So I think that's where peripheral nerve stimulation is going to help us, might help us, especially in these really severe pain patients where we do bring them down. It'll help us maybe maintain them at that level.